No.
Do minutes really matter? That is the question. In my presentation today, I'll explain that minutes do matter in patients suffering from a STEMI, ST elevation myocardial infarction. All too often we hear about people experiencing chest pain and delay going to get evaluation. Results of these delays can have a negative impact on the outcome of that patient. Studies have shown that by implementing protocols, also known as the STEMI system, can improve the outcome of these patients diagnosed with a STEMI. The American Heart Association has started a campaign with a compilation of a STEMI system. I will go over 3 components of a STEMI system and explain why they are important to improve the outcome of a patient suffering from a STEMI. The first part of a STEMI that I will discuss is the use of pre-hospital 12-lead EKGs and how they can positively impact the outcome of a STEMI patient. As mentioned in the article from the Journal of American College of Cardiology, a study showed that a patient who had a pre-hospital 12-lead had a shorter door-to-balloon time on the average of 14 minutes.
How much training is needed sufficiently in performing a 12-lead pre-hospital?
Minimal training is required to learn lead placement and how to operate the monitor to perform a 12-lead EKG pre-hospital. After performing the 12-lead, it is already interpreted. It just needs to be printed out. So you don't have to interpret it. It will read 3 stars and then acute STEMI and then another 3 stars on the printout. In most rural areas, the traveling distance to a hospital can be longer than 20 minutes. So it is very important to obtain a 12-lead pre-hospital. Obtaining a 12-lead pre-hospital, it will not only provide EMS with important diagnostic information to relay to the receiving facility, it also can help determine the destination of this patient. Destination is the key to providing proper treatment of a STEMI. In a 12-lead, it is obtained pre-hospital that can reduce the ischemic damage to the heart muscle by early detection, which initiates rapid treatment. Another component to a STEMI system is early activation of interventional cardiology by emergency departments. This will improve their prognosis. When the ER activates the cath lab directly, the door-to-balloon time goal of 90 minutes increases from 28% to 78% of patients that are treated with interventional cardiology. Delaying detection and then treatment can cause ischemia to the heart muscle, which can cause decreased blood flow supply to the heart.
What other treatments can be used to reduce damage to the heart muscle?
Thrombolytic therapy can be used, usually in place of mechanical reperfusion. There are many complications involved with using thrombolytic therapy, and there is a checklist that must be answered prior to considering thrombolytics. The preferred method for reperfusion in a STEMI patient is primary PCI because of the complications that can be caused by thrombolytic therapy. In the article by Wanda Rivera Bowe, she discusses the complications of using thrombolytics and barriers to using them. There are many patients that don't qualify for the use of thrombolytics. Sue Hughes, the author of Speeding Up Treatment of MI, explains the debates of whether to use thrombolytics or primary PCI. The overall views depends on the time and the potential complications. The third component of a STEMI system that we'll discuss is rapid transport to a PCI center and how it decreases morbidity and mortality of a patient. It is documented that with a STEMI system in place, a patient in a rural setting can meet the AHA goal of 90 minutes door-to-balloon time.
Who is part of the STEMI system?
The public or the patient, educating them to seek treatment if they're experiencing chest pain. EMS to perform pre-hospital 12 leads rapidly and diagnose a STEMI. Emergency departments to activate interventional cardiology and initiate rapid transport to a PCI facility. PCI facility to perform the angioplasty. Immediate transfer to a PCI facility decreases time, which may decrease the length of stay as an inpatient and reduce cost, which in turn will improve the overall outcome of the patient's condition. In conclusion, I previously mentioned these individuals that experience chest pain and delay their own treatment. Well, what if this is preventable? With the STEMI system, which we have learned from American Heart Association research, that we can educate the public for potential STEMI patients of the importance of evaluation of the chest pain that they are experiencing, by training EMS on performing pre-hospital 12-lead EKGs, and by using the vital information, it will aid them in determining the treatment for those patients. In turn, performing these pre-hospital 12-lead EKGs will provide the emergency department diagnostic data to activate the interventional cardiology. And if that current facility is not a PCI capable, then rapid transport can be arranged for the STEMI patient to be transferred to a PCI facility. There is still a debate about using mechanical reperfusion versus thrombolytic, as mentioned in Riviere-Beau's research in e-medicine. The key to decreasing mortality and morbidity in STEMI patients is early detection, no matter the treatment course. Which has proven that time does make a difference and every minute counts. Here I have a graph that shows out of 7,098 STEMI patients who were transported by EMS, only 1,941 of them had pre-hospital 12 leads. The article in the Journal of American College of Cardiology explained that those patients who had 12-lead EKGs pre-hospital had a shorter door-to-balloon time on an average of 14 minutes. So by decreasing the door-to-balloon time, it will decrease the inpatient mortality rate. It is proven that by doing this, it will improve the overall outcome for these STEMI patients.